Hello, everybody. I'm Allison Horan. I'm Director of Strategy and Staff for Access Supports for Living, and I get the distinct honor of moderating this incredible panel. Wish you were here to hear the pregame for us, which hopefully is not nearly as entertaining as what's going to happen next. So on the panel today, we have Linda Muller, President and CEO of Cornerstone Family Healthcare, Michelle McKeown. Did I get it almost right? McKeown?
That's the one. Well done.
Chief Operating Officer for Recap, and Jackie Lawler, who is, Jackie, correct me if I get it wrong, Director of Epidemiology and Public Health Planning for Orange County Department of Health. Get it right?
You got it, Allison. Awesome. You got it.
So we're going to talk for the next, 57 minutes or so about poverty as a social determinant of health, which is a topic that this panel is uniquely qualified to speak on. Everybody is working on this and aware of it in a variety of different ways. So I kind of wanted to start with Jackie to do kind of a brief description. What are social determinants of health? Just to give everybody a good background for what we're talking about.
Sure, absolutely. Thank you, Allison. So it's really about the conditions in the places where people live, where they learn, where they work, where they play, that affect a wide range of their health and their quality of life and outcomes, right? So it's really shaped by the distribution of money, power, resources at a global level, a national level, and all state and local levels as well. And poverty, which is one of the largest social determinants of health, and most organizations call it the single largest determinant of health. Poor people, unfortunately, live shorter lives. They have poorer health than those that are affluent as well. So when we talk about the social determinants of health, it's not just about behaviors. Some people who are choosing to smoke or not smoke, people who choose to exercise or not exercise, eat healthy or not eat healthy. It's really about the most underlying factors that really make the biggest impact on your health. And so there are basically 5 categories, and I know we're going to focus on poverty today, but just to give an overall background about the social determinants of health, really 5 factors that you look into when you're talking about SDOH. So economic stability, so that one being poverty. The second one being education as its own. The third being healthcare, which I'm sure we'll address at some point today. Your neighborhood or your built environment. And the fifth one that sometimes is less talked about, but a social and community context. People's interactions, social connectedness to one another really does have an impact on their health as well. I know we're going to talk about poverty in quite a lot of detail, but those are just overall what you'll see. Again, it's how people live, work, and play, the factors around them that really affect their health.
Yeah, so I think poverty impacts all of those domains in various ways. But Linda, if you could speak to kind of the connection between poverty and poor health. So fundamentally, is access to healthcare the root of the problem?
Well, it's part of the problem. I think there's a whole lot more that's connected to the problem around health outcomes in relationship to the social determinants of health. So if you live in poverty, you probably don't have a car. So how do you get to the doctor? If you live in poverty, Michelle did a beautiful job, and I don't want to take anything away from you from yesterday, but referencing food insecurity or food apartheid. If you're living in the city of Newburgh, where are you going to the grocery store? And if you're at Five Corners in New Windsor, you can go to Hannaford's, you can go to Price Choppers Marketplace, or you can go to ShopRite, and they're all one traffic light away from each other. But that's not the availability in the city of Newburgh or in the city of Middletown. So where does nutritious food come from? If education is not a priority, how does anybody ever get lifted out of poverty? And so that cycle that people talk about just continues to spin. So when you think about health, I think it was Michelle who I'm going to steal this because I stole this from you this morning with my staff. Health expectations on how long will you live. If you live in beautiful Warwick, I mean, if you've ever driven there, Warwick's beautiful. So the life expectancy of somebody in Warwick is 84.6 years. The life expectancy in the city of Newburgh is 74.6 years. There's a 10-year difference. Is it because the people in Warwick are just have a better gene pool? No. They have all those opportunities for health, the connection to a provider, healthy food options, the ability to have a really good experience in school, healthy water supply, healthy environment. Those are the things that affect someone's health. If you can't get a good meal that's balanced, your diabetes is going to be a problem. You will be obese. You will have hypertension. Those are the key risk factors from death from COVID-19 or hospitalization for an extended period of time if those underlying illnesses happen. So why did we see the disproportionate share of those folks getting COVID-19? Because that's the communities where they live. People can't afford an apartment. So when you put 12 or 13 people in an apartment and everybody told you to keep your distance, keep your 6 feet, yeah, how do you do that? So I think everything, if you're going to look at good health outcomes, access is only one piece. Getting to the doctor is only one piece. Health literacy is an issue. Do you understand what the doctor says? Is it culturally sensitive? Do we speak your language? Are you a medical record number or are you a person? And those are all the pieces that sit on top of the social determinants of health.
So, Michelle, put it in context for me in the Hudson Valley in Orange County. What does the poverty landscape look like? I know Linda spoke a bit to Newburgh, city of Newburgh, but what are the other areas that we need to be concerned about as a community?
So as a community, we struggle with poverty, not just in our cities, which are there's better data, and Jackie is definitely the data person, and we have data from our poverty report. But one thing I think just foundationally is that poverty is not an accident, and like slavery or apartheid, it's man-made and can be removed by the actions of human beings. And when we think about, a family's poverty, if you are an individual and make about $12,700, that is considered your poverty landscape, right? So think about your own expenses. Think about your mortgage or your rent or your car payment or your cell phone. If you're a family of 4 and it's, $26,000, where do you fall in that, in that range? And if we look at the poverty just in the county, our poverty rate is 12%. And NYSCA, which is the New York State Community Action Association, does a poverty report every year. And it really does a good job breaking down the differences and the numbers. And if we look at female-headed households in Orange County, the poverty rate is 29.5%. So households run by women or led by women in Orange County is almost 30%, right? If we break it down to the 2 cities, if we think about the city of Middletown, it's 34.7%. And if we look at the city of Newburgh, it's about 57%. So those data numbers are stark and they're frightening. It's how we define poverty, right? Poverty is a chronic and debilitating condition that results from multiple adverse synergistic risk factors, and it affects not just your person, but your mind and your soul. And Linda's right. Your zip code matters. Orange County has amazing and beautiful vistas, but it also has environmental challenges and abandoned buildings and high crime areas. And the health of an individual is almost inseparable from the health of the larger community. And we cultivate, what we cultivate determines our health. So if there is a community with high inequities and community assets are low, health outcomes are worse. If we cultivate good resources and good outcomes for things like infant mortality or substance use disorder or HIV and AIDS, our health outcomes are better. And I think in Orange County, we have places that flourish and we have places that are struggling significantly. And I think we all want to work together to do a better job addressing those things.
So speaking of better job, I grew up in a house where you're not allowed to criticize until you say something nice.
Mm-hmm.
So what do we as a community do well to improve health outcomes? And then we'll get to all the other ways that we can do things better, but what are we doing well? And I think I can start with Michelle because she's the last to go, and then everybody should feel free to jump in.
I think we have some really wonderful community partners who work well together. Recap and Cornerstone work in partnership on a number of different initiatives. We understand that it's not about an ability to pay that gets you access to healthcare. I think that we have a wanting to do better. Right. And I think that I think our need to come together and put action steps to our words. We need to talk. We need to walk the talk. And we need to look at myths and misperceptions of poverty and combat them on a regular basis and call them out as we see them in our social circles, in our social media feeds, and in our communities.
So I just want to echo Michelle that, we're really fortunate in our communities that we don't operate in silos. We cross paths with our colleagues every day. There are some things that we do well, and then there's some things that other people do much better than we do. And being able to recognize those things in partnership is really key and important. But I think one of the most important things on what we do really well, I'm just going to speak from an FQHC, a federally qualified health center's perspective, is by focusing on those communities that are disenfranchised, those people who live in poverty, are undocumented, that are fearful to come into a medical practice. We break down that stigma. The one thing that we should be so blatant for all of us is there was a heroin epidemic forever, right? It's always been there. There was illicit drug use forever, and they were in Black and brown communities, in poor communities. But until that one white kid died, nobody wanted to make the connection that an opioid problem crosses all races, it crosses all economic status, and that it is an issue for everyone. And so when that one moment happened, we became open to the idea that we should have, medication-assisted programs, not just for inner cities or for the people that we always thought were the abusers, but we would take care of everyone. So I think that what we really do well in some practices, patients are seen as people, not as a medical record number or an account number. When you can connect on a granular level between a provider and a patient, or a provider and a client, they are much more likely to trust you and to come in. And that's how you get higher efficacy rates in vaccinations for COVID and every other vaccine, how you can talk about difficult things like, oh my goodness, you have stage 1 breast cancer, and here's how we work your treatment options, instead of not talking about it. So I think one of the best things is our partnerships with the county, with RECAP, with Abilities First, with everyone that we work with. But I think that having a health center whose singular vision is around population health and public health sends a different message to every other provider in the community.
Yeah, I would 1,000% agree with both Michelle and Linda. I think the focus that on population health and public health for the first time may be brought into light, particularly with the COVID-19 pandemic. Lightheartedly, nobody asked me what an epidemiologist is anymore because everybody knows what it is and what we are. But our partnerships are the reason that we are successful in any of our initiatives. I can tell you in the last couple of months, when grant opportunities had come through the county to try to apply for, when we try to go to our partners, there's always someone in the community to say, yes, we'll be there. Yes, we do this. How can we help you? So I think the partnerships that we have are one of the most successful things that we have that we can leverage in order to address the social determinants of health. We really also need to take a look at it and do, when we're talking about doing better from a public health perspective, is to provide that data that's out there. And Michelle gave some really excellent data, granular data, because as you know, I've been saying for the last 12 years here, all data are local. People care about what happens on my census block, on my street, in my neighborhood, in my town, not just in my zip code, not just what's in my county, or, you know, because we're very diverse in Orange County. We've got you run the gamut of what we have here. So when you look at overall impacts, it can tell a different picture for somebody who might be in the city of Newburgh, the city of Middletown, the city of Port Jervis, than you might see in the town of Waukegan. Or if you're looking at rural areas like Cuddybackville, Sparrow Bush, Pine Bush, Walden, there are areas, Pine Island, where we have a large migrant population. There's so many particular factors that are different depending on where you stand. So I think it's really important for us as a public health department, as a county, that we provide that data that's easily digestible to all of our partners in the community and pick out and point out, these are the problems that we really have. How can we work together to synergistically, make change in that direction? Because one organization is not going to be able to do it on its own. And poverty is, in the 80s, we had wars on poverty and we weren't able to address them. So, we really need to talk about how we can continue to partner together and strategize together to address social determinants of health, because that's probably the only way we'll be successful.
And just to quickly piggyback on what Jackie and Linda both said, I think one of the things that we do really well, I think a little bit more for the not-for-profit world than the government world, is around our ability to be flexible and to change quickly. So when there's a tornado in the city of Newburgh, or when a pandemic hits, RECAP is designed for fluidity. So as a community action agency, we can shift very, very quickly to moving to creating a whole new food delivery system in a city, right? Instead of, hey, we have a food pantry, come into our offices and here's a bag of food. We can very quickly move to, hey, we're going to deliver these food boxes, 700 in a weekend to your homes, because we don't want you to come outside, right? We want you to be safe. And I think that, us being able to be flexible that way, Linda being able to put a literal health van on the road, to meet the needs of our neighbors. I think that fluidity is a little bit easier for not-for-profits. But to the counties, major kudos, their ability to get pods up and running and moving and getting shots in arms over the past 6 months has been just monumental. And we have supported and helped and worked on those efforts with them. So I think there's a lot of good things that we do as a collective, and there's much more work to be done.
So I just want to add about the flexibility. We have a saying in our health center: blessed are the flexible, for they shall not be bent out of shape. But if you know a healthcare system, they are tough to move, because we're steeped in regulation and we can't do anything unless somebody tells you you can. But the pandemic taught us, Michelle, just like RECAP, that you can be flexible. And we were flexible that we were able to say, okay, you all got told to stay home. Don't come out. Be safe. And our patients did. They stayed home. We went from 1,300 patient encounters one day to 200 patient encounters the next day. Did that mean that the patients didn't need to be seen? Absolutely not. They still needed to be seen. We just had to figure out how to get them to be seen. And if anybody would have said we could turn our institution virtual, I've been trying to figure out how to do that for years and doctors didn't want to do it, and we didn't want to do it, and you got to have laptops, and you got to do this and platforms and all the other stuff that goes with it. We did it. And so patients were able to stay connected. We saw the greatest spike in mental health services. It is the fastest growing department that we have. And I'm just happy to say we just hired our second full-time child psychiatrist, because the isolation, the fear, the worry, the watching people die, just took a toll on everyone. Kids losing their ability to go to school. I have a 6-year-old granddaughter who went to kindergarten virtually. How does that work? It really doesn't. So I think that what the pandemic has taught us, that we can do better when we have to. And now we know that we can, so we don't have to wait for the next push. We just need to do better.
Yeah, I mean, that's necessity is the mother of invention, I think, is part of it. But I think the other part of it too is there's been a lot of that kind of regulatory relief that providers have been asking for. I know for access, it's mental health and substance use, and the regulations around providing telehealth pre-pandemic were just prohibitive. So when the emergency regulatory relief came and we could support people virtually, numbers went through the roof. And we worked with more people. I think Michelle and Linda and Jackie would kind of bear me out on that, than we ever have during the pandemic, because the need was so great. But which brings me kind of to the next point, which is everybody who's here on the screen is in some way working in mental health and substance use. And there's a lot of stigma associated with it. And a lot of our work is driven toward eliminating stigma. And I had somebody describe it to me once that it's not a casserole illness where somebody has surgery, somebody breaks their leg, you bring a casserole over to the house. If somebody has a mental health concern, nobody's really bringing a casserole over to the house. But there's a similar stigma, I think, associated with poverty. So Linda spoke before around, kind of people not they can't afford to put gas in the car. They can't afford to get to their doctor's appointment. So my question is, how are we engaging people well, or what should we be doing to engage people differently around having them better explain what their circumstances are, so that we can kind of get up underneath to find out what's really going on in a household and provide more holistic treatment that's addressing kind of the full scope of social determinants of health. I feel like there was a lot of question in that, but I have great confidence in your ability to dig in. So, and Jackie, you want to start off on that one?
Sure. I was just thinking exactly what Linda had already said. It's about trust. It's about the trust in a provider for a person to connect with. I think we found that in terms of vaccination. I know we just briefly talked about it for COVID-19, but unfortunately, COVID-19 and poverty really have gone hand in hand in terms of health outcomes when you take a look at it as well. And so having that person that you can have a relationship with, that you are willing to open up with, is really important. So having that primary care provider or that place that you can go to, and the person on the other end is willing to listen or is willing to ask some of the questions too. And I think over the last 5 to 6 years, I think most providers are asking those questions. They're asking questions about food security. We're partnering with all the federally qualified health centers as well as the hospitals in the area, because access to healthy foods and food insecurity was identified as one of the top priorities in Orange County in 2019 when we did our community health assessment. So, a lot of providers are already asking some of those questions, and it's about trust in the community.
So we were really lucky. Westchester Medical Center had an initiative to engage physicians to listen to patients. So physicians, nurse practitioners, PAs, dentists are trained to take charge, right? Patient comes in, I'm sick, I know what to do, I'm going to write you a script, you do this, thank you very much, I'll call you in a day, see how you're doing, goodbye. Well, our doctors went through a training that said, yes, we want you to still be able to take charge and know what to do, but you need to ask one simple question to a patient. What's important to you? Because what's important to the patient may not be what's important to the provider. And we can work and we can educate the importance of some things that the provider has identified. If the patient isn't on their list of priorities, then they're never going to follow through. And by giving a client or a patient voice in their treatment makes all of the difference in the world. That's how you find out what's important to them. What's important to me is, we can't put food on the table, or we are really struggling to figure out how to pay the rent. That may not have a darn thing to do with their asthma, at least they don't think it does, but there is the connectability. So I'm really proud that maybe 60% of the time my docs are saying, what's important to you? And we're going to get it higher as we think about it, and it becomes part of a routine. But giving someone voice in every aspect of their life, if you don't do that, how will we ever learn what someone really needs?
And echoes to both Jackie and Linda, relationships are key. If you're in a Black and a Brown community and you don't understand why there is a vaccine hesitation, or why there is why do you need ID to food pantry hesitation, you're not connected with your community, right? If your FQHC and your hospitals and your public department of health are not working with, RECAP as the anti-poverty agency to look at food insecurity, then there's a breakdown in the response to food insecurity, right? Or housing, or whatever, how we connect to the social determinants of health. But just to go back to your kind of thought on stigma, there is a stigma for those who live in poverty, right? We have a lot of expectations when people come into our offices. You need to tell me who you are, where you are, what you're doing, what your traumatic events are, and hi, I've known you 15 minutes. You happy to share, right? We create a dynamic where all power is on one side, and then if you want something from me, you must give me all of that information, right? And that's not necessarily the service providers. Oftentimes it is the funders who require that information. But I think there's also something that came up yesterday while we were doing presentations for Leadership Orange. And it was when we were doing a hunger banquet and we were talking about the people who needing to access food banks, or when we were talking about, well, why do poor people have so many kids, right? There is more of a focus on catching people who may be going to 3 food banks or abusing access to food than there is about asking the bigger question, right? Why do we still have lines at food banks, right? Why do we live in a community or in a county or in a country where we have people who cannot afford can't afford food, right? We're asking the wrong questions because we've been programmed to believe that people will abuse something that they may get at a free or reduced cost, right? So my response was, well, if people are going to steal toilet paper, or they want 5 extra boxes of 99-cent mac and cheese, you know what? Totally going to give it to them, right? Because it's not like they say, hey, I need a new car, and then I'm going to sell the car that you gave me, right? It's about basic needs. And if you put yourself in the role of somebody who has to come to me adult to adult, and ask if they can have 2 rolls of toilet paper. Think about what that may feel like for them, right? And to, when you think about Linda's question, what's important to you? My important to them may be, hey, let's figure out why you need toilet paper. But for them, it's, I need some toilet paper and some mac and cheese, and can you give it to me and get off my back, right? That's the dynamic we've set up. But there is also a lack of dignity in the process. So instead of asking, why does that person need more toilet paper, or come to a food pantry every week, or drive a nice car when they come to a food pantry, let's frame the question like, why do we need another food pantry? Why do we still have the Armory giving out 700 boxes of food a week, and we are still giving out 250? We're asking the wrong questions, and we need to shift that paradigm.
So it reminds me of a meme that's been floating around, and I was flipping through my Facebook feed this morning, which was, why do heroin addicts have access to free needles, and I as a diabetic have to pay for mine? And I, every time I see it, I'm like, you're asking the wrong question. You're asking the wrong question. So I don't know. I think it's kind of an esoteric question, but for the people who are watching, like, what can they do on an independent level, on a personal level, to help to shift those conversations? Because at the end of the day, that's what we want to do. It's not going to happen en masse. So how does each individual kind of take responsibility for shifting that paradigm? Don't all jump in at once.
So I think it's a choice you make every day. It is on a very small individual level, right? It's a choice you make every day with the conversations. And either Linda or Michelle had already mentioned it already, but how we speak to our family, how we speak to our coworkers, how we speak to our clients, if we're in the health service provider field or the human services provider field, we make a lifetime of choices, and those choices add up. Right. So it is the small things that we do every single day and the interactions we have to try to shift the conversation. And then perhaps is it joining a focus group, joining a volunteer opportunity, volunteering with Michelle, with another organization that might deliver food, with a food pantry, something like that, where it's, an actionable volunteer item. But I think the conversations start small with your family members and your friends, so that perhaps instead of rolling your eyes the next time you see the meme, it's a conversation about, well, why do you feel that way? And I know Linda had mentioned it earlier, is that if we don't have education, or if we don't educate moving forward, or don't make education a priority, things are never going to stay the same. You can't make the same choices over and over and expect a different outcome. So I think it's small choices every day that people have as a small stepping stone to change.
It's a really interesting question about how do you change it? How do you change things? The first thing I think everybody needs to do is to look at themselves and to determine what bias you might have. Asking the question about why is it that somebody who's addicted to heroin can get a free needle, and somebody who's a diabetic has to pay for their needles, in itself talks about the bias, about the haves and the have-nots. And I don't know if everybody's ready to have that conversation. Jackie and I can talk about the public health issues, about why you should give a clean needle to a heroin addict. And we could talk about that ad nausea, because there's science-based about why that's important. But until somebody can really look at themselves and say, why do I think that a heroin addict is any less important than a diabetic? I think because there's no diabetic that I know of that can't get a needle. You can come to our health center and we can give you 340B, and we can make sure that you can get your supplies. No one is ever going to be denied that. I think that there's this inherent, we may say that, oh, no, we're good. We don't see color, and we don't see this, and we don't see that. And unless you take a moment where you actually can look at yourself, look at where you are, and determine what it is that you feel, we're never going to change anything. Politics, as much as I'd like to say should not creep into any of our discussions, creeps into every one of our discussions. And it's always about, what do I have? What do you have? And why do you think you should have more than I have? And we need to figure out how to address it, just simply talk about it, and acknowledge it.
And challenge, when you see the meme on Facebook, how many of us have seen that meme on social media that says, everybody who gets public benefits should be drug tested, right? And, we every time I see that, every time I saw it, I started answering it, this is what happened in Florida and this is how much it cost. And, they caught 2% of the people and the whole cost was $83,000 and they spent $17 million to do the study, all of those things. And then you realize you're just shouting into a vacuum because they don't want the information, right? But I do believe it is our inherent responsibility, especially as people of privilege, to use our voices when those who are not safe enough or scared or not able to talk and say, this is why this is important. Here's what's wrong about your misperception about poverty. The myth that we, everyone who's on poverty is just lazy, right? Well, that's clearly not true, and data drives that out, right? The people that we work with, unless there is a significant disability, in particular in our veteran community, most of our clients work. And if they don't work one job, they work 1.5 jobs, a full-time job and a part-time job. That's not lazy, right? I know a lot of people who work only one job, and it's great that that's their right. But let's also understand that even at $15 an hour, at 40 hours a week, you're still only making $31,000, $31,200, right? Again, look at your expenses and look at your income. And that's, by the way, 31.2 before taxes, right? So, getting ahead doesn't mean that somebody else needs to fall behind. Equity, equality, justice, all of those things have a place, and finding a balance where, equity is one thing and something that we should all strive for. And, if you ever look at RECAP's logo, if it's rotated correctly, and it should be, it is one hand reaching down to pull the other person up. It's about providing a hand up when someone needs one. High tide rises all boats. So let's start filling the pool. Linda, that was for you. Let's start filling the pool so all boats rise, right? And if you want the bigger boat, have the bigger boat. But I'm going to make sure that the person in the dinghy next to me comes along with us. And I think that should be something that we all strive for.
So as Michelle walks me perfectly into the next question, which is, from within the framework of social determinants of health, what's the difference between equity and equality?
We have a long way to go. Right? So equality is we all get the same thing, right? And there's a wonderful cartoon that I use in my classes that there are 3 people standing behind a fence, right? And there are 3 people and everybody gets a box to stand on, right? But the person who's 6 foot doesn't need the box, but they got a box because it's equal. But the person who's 4 foot needs 2 boxes, right? That's equality, but it's not equity. And I will take it one step further for justice. And justice is taking down the barrier itself, right? Taking down that fence and putting up something everybody can see through, right? So we strive for equality. We work towards equity. We achieve justice. That is what we have to do, and we all have to be going in the same direction. And just because I can see over the fence and Jackie can't, doesn't mean I lose something by taking down that barrier that stops her from seeing the same thing I'm. And we have to stop thinking of, if you get, I don't. It's not punitive, right? It's about inclusivity.
And I think that that's a lot of what's at the root of the social determinants of health kind of across the whole span, which is if I live in a community where my kid goes to a fantastic school, my child's not losing anything by improving the public school education for the kid in the next district over. So I think that's, yeah, your point about equity is quite well taken. And speaking of kids, we see there's a lot of programming aimed at improving outcomes for children and a lot of programming aimed at improving outcomes for adults. Do we see enough multi-generational approaches? And if not, what can we be doing better?
So if you're looking at the multi-generational approach, it changed over time. So when I was growing up, my grandmother lived really close to us and my mother, so we had generations all kind of living next to each other. The integration isn't always there. Kids pick up and they go to California and mom and dad are staying in Jersey and somebody else is going someplace else. So the connection of family becomes different. But when you look at multi-generational support in the healthcare world, I don't think that we do a bad job in identifying what the needs are by cohort of age. So the need of a 6-month-old is going to be very different from the need of a 68-year-old, and being able, the health is just one component piece. And so, I'm lucky in my health center is that we've got caseworkers and we've got care managers, and you take I think it was Michelle said that holistic approach, or maybe it was you, Allison, that this is bigger than just one thing. So, you have a patient who comes in who's 80 years old in a walker, has got comorbidities, but lives in an apartment that they really can't get up and down really easily. So the dynamic of what the needs are intergenerationally or by age cohort is one that we have to really kind of look at, and barriers have to be brought down. So whether you're a 5-year-old living on South Lander Street or a 5-year-old that's living in Cornwall on Hudson or Tuxedo Park or Bombville, the same needs clinically are the same regardless of where you live. The problem is where you live dictates how well you get the outcomes. And I think that is in itself an inherent problem. Until we can recognize that health and wellness is above revenues, I think, it's an issue. There were people in the beginning of this pandemic that were charging $200, $300 to get a test for COVID-19 that was saying out-of-pocket cost. You want the test? It's $250. Seriously? Really? How did that happen? Why did that happen? Why do providers make a choice that they refuse to take a certain MCO? You just knock out a whole cohort of patients that can't go to you anymore. That's establish a relationship with your doctor. Why did those decisions get made? So I think as you look at this whole issue about how healthcare is accessed, what are the outcomes that you should get, what should you expect, how should that change? There's a much greater conversation that needs to be had, but not everybody is willing to come to the table.
I think other cultures and communities do intergenerational support better. I think both Linda and Jackie talked about it before. I think the social connectedness that was missing during the height of quarantine is kind of showing us the damage now. There are a lot of people really struggling. We partnered with Office of the Aging, and we were delivering hot meals to seniors throughout the county for about 9 months. And there were some days that our staff or our volunteers were the only person one of those seniors would see in an entire day. In one of those cases, when the volunteer went back the next day, there were 2 meals there, the one they were delivering that day and the one from yesterday. And they were concerned that they didn't see this particular senior who would always come to the door. And And we called for a well check, and that senior was on the floor, and it was a definite medical crisis. And that lack of connectedness, that lack of your ability to be part of something greater, it is problematic, I think, in our community. We spend way too much time on screens, right? Not really paying attention. And, one of the things that, Linda and I said a couple of weeks ago when we saw each other for the first time was, we're huggers, right? We miss that connectedness to people. And I think as humans, we are built for social interaction and love and intimacy and all of those things. And I think when that is absent, our health overall declines. Our mental health, our well-being really begin to struggle. And creating that connectedness again is going to take some effort, because we've lost the ability to do that a little bit. And I think we have a long way to go in order to help everybody get past that feeling of isolation, even now as we start to kind of open back up.
Yeah, I don't know how much more I could add. Linda and Michelle really said it beautifully, but I think we're going to see the long-term effects of this pandemic and COVID-19 well past the surges that we're, experiencing, these waves of high prevalence of disease, low prevalence of disease, as vaccinations are thankfully increasing and people are not spreading the disease as much. But the long-term impacts of isolation, of mental health of individuals who are homebound, as we continue to do vaccinations to homebound individuals every single day as we try to get them at least more safe. We see it. We'll get calls. They'll say it's the best thing that happened to them all day was, when a nurse came to their door to just have a few moments with them. And, again, we see it in our child age population as well. We see individuals who are, who didn't go to school, who couldn't go to school, who had to be virtual because their parents are home and they have to stay home. Sometimes there were choice, sometimes there weren't any choices. So I think our population health and our public health and all of the things that even when COVID is over, we're going to see, unfortunately, a lot of lasting impacts. And I think it will disproportionately, it will disproportionately affect those people who are in poverty. It will disproportionately affect Black and Brown communities, as COVID has disproportionately affected those communities in Orange County, in New York State, in all of the country, around the world, quite frankly, depending on where you are. So COVID has made our job a whole lot harder. There are some things that, we're very grateful for, like Linda had mentioned before, the ability to pivot, Michelle's ability to pivot and be flexible on a dime and provide services to people's homes and telemedicine and things that we didn't think were possible until we were forced to actually do them. There are some good things that will stay, but it will be quite the challenge, quite frankly, when we're looking at other outcomes from this. I am very worried about our poverty levels. I'm very worried about those in our undocumented populations that didn't have the benefit of being able to claim unemployment, even though they are now not employed because we're not doing some of the traditional fields that we were for almost a year. And so what happens then when we get those eviction notices and, we're trying to deal with clients that are calling us, asking us for help? What do we do now? Right. So, there are so many pockets in this community that are going to be disproportionately affected by COVID moving forward. So it made our jobs a little bit harder, but I hope that our partnerships, our strong suit where we started this conversation, will propel us to being able to adequately, or at least try to address some of those issues.
And Jackie, just to that point, in particular around our undocumented communities, there is going to be a real crisis around eviction because they are not eligible for the monies coming out, the eviction moratoriums, unemployment. And, it goes back to, define essential worker, right? People seem to be fine when undocumented workers are working in the fields and picking fruits and vegetables and getting them to restaurants and to our tables. But when we want to or need to pay them for that work or make sure that they are taken care of when those industries had to pull back or shut down, then it's like, whoa, well, they should have followed a process, right? So I think that will be the conversation to be had moving forward, because I think, again, a lot of myths and misperceptions and fear mongering about our undocumented community. We tend to overlook the value they bring to each community. And I think that there's going to be a lot of families struggling without a lot of resources. And we as a collective are going to have to come up with ways to provide support and resources in order to make sure that those families are safe and healthy as well.
So Michelle just talked about the collective. I think there is a really good dissertation that could happen if somebody's interested in publishing, is if we go back and look at what community and family was like, and I don't want to think that we have to go back to the good old days, but what family and communities did when I was growing up. You watched out for each other. You took care of each other. If there was an injustice or something that happened, somebody went out and tried to right it. Now, maybe they didn't do it the right way. I grew up in an Italian neighborhood, so I don't need to say more than that, right? But that kind of stuff happened. Family and community was a priority, right? And then you fast forward to where we are right now, and we are totally disenfranchised. We don't think that we're accountable to anybody but me, and that the larger group, that generational concept that we are part of something bigger. COVID didn't help with the isolation, but there's something more inherent about what put us to where we are, that we don't feel responsible, that somehow our hands don't get dirty in all of this, when in fact it certainly does. And so I'm not quite sure how we got so disconnected, but that did happen. It happened in families. Here's a little secret, Jackie. Now you can't get me because, we're able to go visit again. During the entire pandemic, every weekend on a Sunday, my family, all 14 of us, or Harry, if he came over 15, in the height of the pandemic, went to church virtually together in somebody's house. And we broke bread together every Sunday. And I think that's how our mental health was okay. I got to see my grandchildren, even though there was a risk involved. I got to see my kids and their spouses. We made a conscious decision that said family had to come first, and that we would fight whatever we needed to fight collectively. We did our risks. We made our pod. We stayed safe. We wore our masks. We did what we needed to do. But, and then my kids would say to me, Mom, we're the outlier as a family. We kind of still like each other, and we figure that if one's down, we've got to be there. I don't know what that is. I don't know how it got lost, but I think that if we could figure out how to make ourselves accountable for more than just us, we might be on the road to some kind of recovery, to change the societal views of what's wrong in the world, to see what might be right in the world.
Agreed. And I think during our session yesterday, Linda Serto from Access had a really beautiful kind of anecdote around her neighborhood, that when she was so very sick with COVID, they would, the neighbors would do a small thing, leave something. When she was better, she and her husband and her 2 children made the Cosmos takeout night their thing, right? And then they would share part of that meal with their single elderly neighbors. And then those neighbors would then put brownies on the front porch. And she talked about it just being a light touch, right? Just being a little bit of connection, a little bit of light in a darkness. And I think that hopefully, if COVID has taught us anything, it's about kindness and connection has a direct correlation to health. And if we can do both of those things intentionally every single day with each interaction, I think we as a community would be better off. Individually, we'll feel better, right? You do feel better when you do something good. Like when you go to the gym and you get on the elliptical for 50 minutes, even though you swear the entire time you're on the elliptical, you feel better after, like, the whole day. You're like, I went to the gym, right? I think the same thing it happens when you connect with somebody and you have a positive interaction. I think that stays with you. So then you have seeds on both sides that are being nourished and can grow.
Well, I feel like looking at the time, it's 12:57, and I can't imagine a better note to leave this panel on. So I want to thank all of you for your expertise and your great thoughts and your leadership in the community around improving health outcomes and quality of life for everybody.